This is Joe Shaker. I'd like to introduce Dr. Catherine Zhang. Catherine joined us at MCW about a year ago as an assistant professor in endocrinology. She did her undergraduate at Northwestern, medical school at Ohio State, did her endocrine fellowship at the Mayo Clinic. And Catherine has a particular interest in adrenal masses and expertise in that, and also has published a lot on the skeleton in patients with what's called MACS, which is mild autonomous cortisol secretion. And she is a wonderful addition to our group. We really like having her around. And she's going to talk about MACS and the skeleton. Catherine?
Perfect. Thank you, Joe, for the introduction and for having me here tonight. I'm just going to go ahead and try to share my screen. So as Joe mentioned, my interests are primarily in adrenal nodules and adrenal hormone excess. So tonight I'll be speaking about mild autonomous cortisol secretion, which is a hormone condition we see in adrenal nodules and its impact on the skeleton. So I don't have any relevant disclosures. And I wanted to start by just briefly reviewing the diagnosis of mild autonomous cortisol secretion, which I'll just shorten to MACS for the rest of the talk. And then we'll move on to looking at fracture outcomes, and then finish by looking at different skeletal parameters and possible mechanisms that may mediate increased fracture risk for this group of patients. And I just wanted to give a quick note about terminology, because mild cortisol excess from adrenal nodules is an entity that's been known by many different names over the years. So historically, it's been called subclinical Cushing syndrome. We don't use this term anymore. It's misleading because it is associated with clinical consequences, of which we'll talk about. And then if you look at the adrenal nodule literature, there's some other terms that are used interchangeably with MACS, including mild autonomous cortisol excretion, MACE, or autonomous cortisol secretion. So MACS just tends to be my personal preference, and it's also the term that's used in the new updated adrenal nodule guidelines that were just published earlier this year. So adrenal nodules themselves are fairly common. So we see them in about 5 to 7% of patients who undergo cross-sectional imaging scans that cover the belly. They're often incidental findings, so seen in people who are having imaging scans done for other reasons. And because of the increased number of imaging scans that are being performed and improved imaging techniques, we are seeing adrenal nodules in clinical practice more and more frequently these days. So this figure on the right is from a population-based study that we did in Olmsted County, looking at the incidence of adrenal nodules over the past 2 decades. So the purple line represents overall adrenal tumors, and then the other colored lines represent different modes of discovery. So between 1995 to 2017, the standardized incidence rates of adrenal nodules increased by about 10-folds. And as you can see here, this is primarily being driven by incidentally found adrenal nodules. So even though they're incidentally found, these adrenal nodules are still important to work up. So everybody who's found to have an adrenal nodule should undergo screening for cortisol excess. When we look at cortisol production from an adrenal mass, it's likely occurs on a continuum, but we broadly classified into what's normal versus abnormal based on the dexamethasone suppression test result. And that threshold of what's considered normal versus abnormal has shifted a little bit over time. So using the current guidelines, next day cortisol of 1.8 micrograms per deciliter or less is considered normal. This is what we would call a non-functioning or non-secretory adrenal mass. And then a next day cortisol over 1.8 is considered abnormal. So previous adrenal nodule guidelines used to differentiate between a next day cortisol of 1.9 to 5 and then over 5. But in the newest guidelines, this distinction is no longer present. And then compared to patients with Cushing syndrome, patients with MACS, they have milder cortisol excess that don't lead to the typical physical phenotype that we associate with Cushing syndrome. That being said, kind of physical exam features can also occur on a continuum, and sometimes you do see a little bit of overlap. When screening for adrenal-dependent cortisol excess, there's some additional considerations to think about. So the first is just, was the dexamethasone suppression test performed correctly? So did the patient take the dexamethasone? And if they took dexamethasone, was it adequately absorbed to interpret the test results? So I worry more about dexamethasone absorption in patients who are very obese, patients who've had a previous history of gastric bypass surgery, or sometimes people who are on medications that induce rapid metabolism of dexamethasone. So for those patients, and actually in every patient, I think it's helpful to obtain a dexamethasone level when you do this test. If the level is suboptimal, the dexamethasone suppression test can be repeated with a higher dose. So sometimes I use 2 milligrams, and sometimes we go up to 8 milligrams as well. For patients who are on oral estrogen, the oral estrogen can increase the cortisol binding globulin, and that can make the total blood cortisol look higher. So in those cases, if the patient can't stop the oral estrogen for the testing, you could consider getting a free cortisol measurement instead. And then additional tests that are helpful. So I usually end up getting an ACTH and DHEA sulfate. So a low ACTH and a low DHEA sulfate can help support the diagnosis of cortisol excess from the adrenal glands. And then for salivary cortisol and 24-hour urine-free cortisol, those tests can be ordered, but they are oftentimes normal in MACS. So what is the impact of MACS on clinical outcomes? I think the first part to understanding this question is just to try to understand what happens to adrenal nodules over time. So this was a large systematic review and meta-analysis of almost 3,000 patients with adrenal nodules. They were followed for a mean of 50 months, so I think more than 4 years, and the change in kind of hormone status over time was assessed. So about 4% of patients who started out having non-secretory or non-functioning adrenal nodules progressed to having MACS, and then a smaller percentage, so less than 1% of patients with MACS, ended up developing overt Cushing syndrome on follow-up. So I think this shows that MACS is not necessarily a high risk condition for developing overt Cushing syndrome, but it's also unlikely to resolve. So MACS doesn't go away with time, and so over long periods of time, even mild amounts of abnormal cortisol secretion can lead to different clinical consequences. So this includes hypertension, diabetes, obesity, dyslipidemia, and osteoporosis. And assessing for these clinical consequences is important when you see a person with MACS. The presence of these comorbidities can help guide decisions of whether the patient may benefit from surgical treatment with adrenalectomy. So I'm going to move on now to looking at fracture outcomes specifically in MACS. So there's been multiple cross-sectional studies now that show that patients with MACS have a higher prevalence of fractures compared to patients with non-functioning adrenal nodules. I've summarized the main studies in this table here. Unfortunately, there's not enough patients, or there hasn't been any pooled meta-analysis on this data yet. And I just wanted to highlight a couple things that I found interesting. The first is fracture type. So all of these studies, with the exception of the last study, looked at morphometric vertebral fractures. So these were fractures that were identified based on retrospective review of spine imaging, and they weren't necessarily clinical symptomatic fractures. The fracture prevalence was also pretty high, so up to 82% in one of these studies. I think part of this may be that the definition of MACS, like we talked about, has not been consistent over the years. So the earlier studies used the DST cutoff of 3, and this likely represented a group of patients with more severe cortisol excess than that's defined by the current guidelines. This last study here was just published earlier this year. It was a fairly large group of patients, and for the definition of MACS, they did use the current DST cutoff. And for fracture type, they did examine both clinical fragility fractures in addition to morphometric vertebral fractures. So if we look at the study in a little bit more detail, The prevalence of fragility fractures, although lower than reported in the other studies, was still higher in the group of patients with MACS compared to those with non-functioning adrenal nodules, so 34% versus 24%. The majority of these fragility fractures were, again, asymptomatic vertebral fractures. Only a minority, so 30%, had a clinically symptomatic low trauma fracture. And then when we look at vertebral fracture severity, mild vertebral fractures were more frequent in MACS, and they really accounted for the difference in vertebral fracture prevalence. So in looking at moderate or severe vertebral deformities, there were no significant differences. So in this study, they also analyzed the data separately based on sex and menopausal status. And I thought some of these results were interesting. So when looking at just postmenopausal women, patients with MACS continue to have a higher fracture prevalence. But when looking at just premenopausal women and in men, the difference in fracture prevalence was no longer significant. In postmenopausal women, the 1 milligram DST cortisol, so the severity of cortisol excess, was an independent risk factor for fractures. And other risk factors that were identified included a positive smoking history and age. And looking at men, age was actually the only risk factor identified for fractures. So the DST cortisol was not an independent risk factor here. And so I think this results suggest that MACS may amplify the age and sex-related fracture risk that exists, particularly for postmenopausal women. And men, at least based on this study, seem to be relatively protected from some of the skeletal consequences of MACS, but this hasn't been shown in any other studies yet. I think overall, the cross-sectional data suggests that patients with MACS do have more fractures, and these fractures tend to be vertebral, asymptomatic, and mild. But kind of the risk for fractures long-term and whether treatment mitigates this risk is more unclear. There's unfortunately been very limited longitudinal data in this area, particularly ones that kind of use a current DST cutoff for MACS. To date, there has been just one kind of longitudinal study that has looked at adrenalectomy and its impact on vertebral fractures on follow-up. So this was a study out of Italy where they, for every patient that was diagnosed with MACS, they offered them the option of having surgery, so adrenalectomy. So 32 of these patients went forward with surgery, and 23 patients elected for observation instead. And these patients were followed for a mean of 30 months. And what they saw was that patients who were followed conservatively, so those who did not have surgery for MACS, were more likely to develop new vertebral fractures on imaging compared to the surgical group. And then surgery was associated with 30% vertebral fracture risk reduction. And this was independent of age, sex, spine BMD, 1 milligram DST results, and then prevalent vertebral fractures as well. And I'll just point out here again that the DST cutoff they used here is 5, and the ones that are in the current guidelines is 1.8. So I will finish by just looking at a couple different skeletal parameters that may be helpful to aid kind of fracture risk prediction. Similar to other secondary causes of osteoporosis, fracture risk in MACS may not be fully assessed by bone mineral density testing. So although the cross-sectional studies consistently show that patients with MACS have more fractures, bone density by DEXA is not always reduced. And patients with MACS appear to be a higher risk of fractures at any kind of given bone density category compared to the counterparts with non-functioning adrenal nodules. So normal bone density, osteopenia, and osteoporosis. And then as we've talked about before, MACS is the independent risk factor for fracture, so that's irregardless of bone mineral density testing. So this suggests that other skeletal parameters may be important in mediating fracture risk in MACS, and this is from a review looking at patients who are on exogenous glucocorticoids. So some things to think about: bone turnover markers, bone quality, and then perhaps muscle weakness and an increased risk of falls. So to review some of these skeletal parameter data, I'm going to be sharing some of the results from the study I worked on when I was a fellow at Mayo. We were interested in looking at bone and muscle outcomes in patients with MACS. So this was a cross-sectional cohort study with prospective enrollment. So between 2019 and 2022, we enrolled 75 patients with MACS from the adrenal clinic, and these patients were matched by age, sex, and gonadal status, so essentially premenopause or postmenopausal for women, to subjects that we recruited from the community. All of these study participants underwent 2 different research visits. The first visit was clinical, so it included a bone health interview and then different functional measurements, including hand grip strength, timed up and go tests, and then the 6-minute walk test. And then the second visit was done in the clinical research trials unit. It consisted of a blood draw for bone turnover markers, a bone density scan with trabecular bone score, and then high resolution peripheral quantitative CT for bone microarchitecture. So in terms of bone turnover markers, we found that patients with MACS had decreased levels of osteocalcin compared to controls. So this is consistent with a few other studies that show that patients with MACS have decreased markers of bone formation. There are no significant differences seen in markers of bone resorption or sclerostin. So I will say that the published data on bone turnover markers in MACS is a little bit discrepant. So not all studies show a consistent difference. And this may be related to the nature of MACS itself. So bone turnover markers tend to be more robust when there's something very dynamic going on in the bones. And we may not see this with MACS because it does tend to be more of a chronic condition with mildly abnormal cortisol levels over a long period of time. So this might not be adequately reflected by bone turnover. In looking at bone density by DEXA, we did not see a significant difference in bone density at any of the sites measured. So this included the lumbar spine, the total hip, the femoral neck, and the distal radius as well. However, we did see that trabecular bone score was reduced in patients with MACS compared to our controls. So as everyone knows, trabecular bone score is the indirect measure of bone quality. It's obtained from applying a software program to a standard DEXA image. So a high trabecular bone score means that the bone microarchitecture is dense, it's well connected, and there's little spaces between the trabeculae. Conversely, a low trabecular bone score suggests that the microarchitecture may be incomplete, may be poorly connected with wide spaces between the trabeculae. And so these results showing that bone TBS is reduced in patients with MACS suggest that bone quality is important in mediating fracture risks. And in other studies that have looked at TBS and fracture risks in patients with MACS, TBS has been found to correlate both with vertebral fractures at baseline and new fractures on follow-up. Another technology that can be used to assess bone quality is high-resolution peripheral quantitative CT. This is primarily used for research purposes and not in clinical practice. So high-resolution peripheral quantitative CT allows for in vivo assessment of bone geometry, volumetric bone density, and microarchitecture at high resolution. It overcomes some of the limitations we see with DEXA scans. The bone size and volumetric bone marrow density can be measured independently, and then trabecular and cortical parameters can also be measured separately. So this is an example of what high-resolution peripheral quantitative CT images may look like. So this can be obtained from the distal radius as shown here, and also from the distal tibia. So from the site or the region of interest, a stack of cross-sectional CT slices are obtained, and this is used to reconstruct a representative 3D image. When we look at our high-resolution peripheral quantitative CT results, we saw that patients with MACS had altered microstructural changes, and this was in the trabecular bone compartments. And there's one other published study out there that shows similar kind of trabecular bone changes in patients with MACS. So I think these results support that, again, bone quality and bone microarchitecture seems to be important in MACS, and some of these changes seem to happen sooner or earlier than changes in bone density by DEXA. So frailty and falls are also important risk factors for fractures. Patients with MACS can accumulate multiple cortisol-mediated comorbidities that may make them more frail. So this was a retrospective study that was done at Mayo Clinic, specifically trying to assess frailty in patients with MACS compared to patients with non-functioning adrenal nodules. So in this study, a frailty index was constructed from 47 different variables. This was based on the deficit accumulation approach, and these variables included different self-reported comorbidities, symptoms, and then activities of daily living. So using the frailty index, patients with MACS were more likely to be classified as frail compared to patients with non-functioning adrenal nodules. And if we look at specific symptoms, patients with MACS were more likely to report a tendency to fall, weakness in their arms and legs, and difficulty climbing 2 flights of stairs. So this suggests that perhaps patients with MACS may have underlying deconditioning and muscle weakness that, again, may predispose to falls and fractures. And when we looked at our data from physical performance in the prospective MACS cohort, this did seem to confirm some of these self-reported symptoms. So patients with MACS had weaker normalized grip strength compared to controls. They took longer to complete the timed up and go test. And then they also covered less distance on the 6-minute walk test. So again, patients with MACS may have impaired physical performance, and this may be additional risk factor for falls and fractures over time. So to summarize, adrenal nodules are very common, and everybody with an adrenal nodule should undergo screening for mild autonomous cortisol secretion. The best test to do this is a 1 milligram dexamethasone suppression test. Studies have shown that patients with MACS have a higher prevalence of fragility fractures, and these are primarily going to be vertebral, usually asymptomatic and mild, and kind of warrant assessment of skeletal health. These are kind of the current recommendations given in the adrenal nodule guidelines from the European Society of Endocrinology. So we suggest screening patients with adrenal insulinomas and MACS for vertebral fractures and to consider appropriate treatment of these conditions. So this is a little bit vague. I guess what I do in my personal practice, I think it's important in all patients with MACS just to get a clinical fracture history and then to do assessment of fall risk. And then I usually consider getting a DEXA scan with addition of a trabecular bone score and a vertebral fracture assessment if possible. And then, the longitudinal data is quite limited, and that really precludes any discussion about how treatment might affect fracture risks in patients with MACS. But there is some limited data that suggests adrenalectomy may improve future fracture risks in this population. Okay, so that's all I have. I'm happy to take any questions or comments.
Catherine, that was terrific. If you have a question, why don't you just unmute yourself and I'll hold.
Yeah, Joel, I have a question. I agree. Great talk. And just one of your first slides spoke to the prevalence of adrenal masses, and I think you said 8%. Is that correct?
Yes, about 5 to 7% of patients who have cross-sectional imaging. So these are based on radiology series. And just because there's more and more scans that are being done, the number of adrenal nodules that are being discovered is pretty high.
So can I make a comment? Well, go ahead, Neil.
So it's really common, and we're probably missing it.
Yeah, yep.
So radiologists will sometimes not report them, or in the past, in our system, they said it's benign, no further workup or no further evaluation required. Whereas now our place has changed to biochemical evaluation needed as appropriate or something like that, because they were just blown off.
Yeah, so adrenal nodules, a lot of times if it says benign on the imaging report, that does not mean they might not have cortisol excess. And unfortunately, a lot of these nodules, so when we looked at different studies, probably only 10–15% of these nodules have an appropriate biochemical workup. We have kind of looked at our data to see if, the addition of the additional recommendations on the radiology report improves the rate of patients who get adrenal nodule workup. And unfortunately, it seems to be quite low still. So only about 15% of patients, even with the recommendations given in the imaging report, have some type of hormone workup.
Wow.
Yeah.
Wow. I mean, obviously we're endocrinologists, so we've seen adrenal mass and we think about it, but I think that the idea that only things that could be cancer should be commented on is a bad idea.
Yeah.
No.
Yep.
Hi, this is Tyler Prout. Can I add a comment here?
Of course.
Yeah, so I'm actually a radiologist, and this is kind of a timely subject because this has actually been batted around a little bit among what's called the Engaged Forum at the ACR. So nationally, radiologists will put in questions, and this topic just came up within the last month. So the ACR created white papers for guidance and back in 2017, and in that white paper, they said to consider adding the comment to consider workup, and that's been recently reviewed and said, well, all of the relevant societies like yours, endocrinologists, and all said, well, they all say the same thing, is that they should be worked up. So and that discussion has kind of gotten traction lately, and you may see more of the reports saying to actually that will recommend biochemical workup if not already performed. A lot of times, going back to the earlier comment about the guidance we give, is that if we can diagnose an adrenal adenoma on imaging, we'll say that there's no more imaging follow-up recommended, is probably the more correct statement with that.
I agree completely. In fact, that's what we suggested, that they change the term to, but I like your idea that no additional imaging is required. However, the patient should be biochemically, whatever the words are, not considered, but just should be done if not done yet. So I think that's a great idea.
Yep, and that's the rub, because the actual 2017 article that the ACR had put out was they were divided amongst the the committee, and it was consider, and it clearly probably should be stronger than that. Thanks.
Thank you.
This is Paul. I have a question. Which patients who present with fragility fractures, and I'm assuming we're really talking about the spine, I'm a spine surgeon, so I'd be interested in this, should be biochemically evaluated for this mild form of hypercortisolism? Because I certainly would not recognize that patient at all.
Yeah, and I think that's the hard part, in that some of these patients don't look like the classic, cushingoid patient, which you think about evaluating. But, a lot of people get imaging scans these days, and I think maybe, a short answer is that if you look at prior imaging, there's, evidence of adrenal nodule, and there's a comment about adrenal nodule. I think those patients should get a screening with a DST.
But we would see people with, atraumatic spine fractures that maybe their bone density doesn't look that bad, or they're younger. Is that the kind of patient we should pull the trigger and do this dexamethasone suppression test?
Yeah, I guess I don't see maybe too much harm about being, more broader about screening. So patients with MACS do tend to be younger, so like in the 40s, 50s, and female.
So
typical
Catherine,
demographic.
can I make a comment? So in patients with osteoporosis,
Yep.
I have a group of situations in which I screen them for Cushing's. And so I'm going to give you an extreme example. If I have an 85-year-old with a compression fracture who's 110 pounds, probably no. But if I have a 50-year-old man with 4 compression fractures, I'm definitely going to screen him for Cushing's, among a million other things. So if somebody has an adrenal mass, if they have unexplained lower extremity stress fractures, which has been reported, in Cushing's. So there's a group of things where I would screen. So the patients that Catherine's talking about usually already have a known adrenal mass, and that's a no-brainer. But the other greater question is, what in the patient with osteoporosis who doesn't have that? You have to figure out who to screen, and it's a more complicated question.
Yeah. This seems very analogous to MGUSs to multiple myeloma. Am I correct in that? I mean, this almost sounds like the same kind of situation.
Yeah, I think it's pretty, yeah, from what I've seen of the MGUS data, and I think it's pretty similar. And I would just comment that, a lot of times, when we diagnose a patient with MACS, they probably have had it for years and years beforehand. It's not recognized, it's not tested for it. So it's, a lot of the comorbidities we see at baseline or prevalence is probably due to kind of years and years of a little bit of too much cortisol over time.
So let me ask you a question. So in those patients with osteoporosis that we don't, and have a vertebral fracture that we don't have an adrenal mass, what would you recommend to test as part of their secondary osteoporosis blood work? What would you recommend? Going straight to the dexamethasone test? I mean, if we have high clinical suspicion, what would you suggest to do?
I guess a high clinical suspicion for maybe cortisol secretion, or sorry, I might have missed the beginning of the question.
I'm sorry, what blood test would you order? What blood test would you order? What blood test would you recommend to order as first line?
So you're screening a patient with osteoporosis who looks Cushing-like. What test would you do?
So, a patient who looks Cushionoid, I might start actually with salivary cortisol measurements. So salivary cortisol tends to be a more sensitive testing for patients who have more kind of overt features of Cushing's.
That's what I typically do. Two late night salivary cortisols.